Okay. Well, hello and welcome everyone to the 5th session of the 2020 virtual Clean Med series. We are very pleased to bring you to this session, Collaborating to Build Resilient Healthcare. My name is Stacia Clinton, and I'm the Chief Program Officer of Healthcare Without Harm and Practice Green Health. And it is my pleasure to be moderating your session today. Before we get started, I just want to share a few notes and announcements. We'd like to thank Kaiser Permanente for supporting our virtual series this year. And while we look forward to future years when we can connect in person, we recognize the challenges that we are all facing these days. And that's why we're excited to let you know ahead of time that CleanMed 2021 will be an even larger all digital experience. So we will share more details in the coming months, and we look forward to your participation in a safe and exciting virtual CleanMed 2021. For some logistics, just note that this session will be recorded and made available afterwards. We acknowledge that 60 minutes is not a lot of time to glean all the knowledge and experience of our 3 excellent speakers today. And so we've opted to try a new format, and we'll see how it goes. We will hear from our speakers multiple times throughout the session while they share background, and then we'll move into a facilitated discussion. However, we're not going to have a Q&A with the audience today. Rather, we've allotted our chat box as a facilitated discussion for audience members throughout the session. My colleague, Shanda Demarest from Practice Green Health, will be in the chat box with you and is there to facilitate your conversation. We welcome you to share insights, offer questions, even share highlights about your work in the chat box as they pertain to the topic today. This is an opportunity for attendees to share as much as the speakers. Our only request is that you refrain from any advertisements of products and services. We will be circulating the highlights from the chat box discussion after the session. So if you do have questions for speakers, you can certainly place those there and we'll pass them along to our speakers from today. You can also use the chat box in case you have any technical issues, and we'll do our very best to address those. We have over 400 registrants for the session today, and we'd like to know a little bit about you. If you would please take a moment just to respond to this short poll telling us which represents the primary nature of your organization. And then once you've done so, please click submit at the bottom of the poll window. While you are doing that, I'm actually going to introduce our speakers for today. We are planning to discuss a bit about how the current health system often fragments public health, hospitals, and communities, rather than recognizing them each as key pillars in a successful health system. Amidst the COVID-19 pandemic, existing silos have really even become more apparent. Our speakers today represent these segments respectively and will share how the current realities are impacting their ability to support the health of our communities and how this has challenged or accelerated collaborative opportunities. So I'll start by welcoming Dr. Elizabeth Gillespie. She's the Assistant Professor of Medicine at Denver Health. Dr. Gillespie has represented the Society of General Internal Medicine on the steering committee for the Medical Consortium on Climate Change and Health. Most recently, Dr. Gillespie is leading a study on the social determinants of health, high temperatures, and health outcomes in a retrospective analysis of the Denver health patient population. We are also joined by Heather Hodge, who is the Senior Director of Community Health at the YMCA of the USA, providing support for the Y's Federation of 800 individual 501c3 organizations throughout the country, who are individually and collectively working to help all community members to live healthier lives. We also have Chip Amo, current Director of Sustainability at Henry Ford Health System. Chip is active in the community, including 8 years of service on the board of the nonprofit Neighborhood Service Organization in Detroit. Prior to joining Henry Ford Health System, Chip worked as a legislative counsel for the American Medical Association. So welcome to all of our speakers, and thank you to all of you for completing the poll. Let's take a look at our results. Okay, so it looks like we have a majority of folks from hospitals today. We have a few from some other healthcare facilities and community health centers. but a good representation here, that sort of a sampling of the whole. So good to dig into the discussion here today with all of you with us. So to start off today, I'm actually going to join our speakers just to provide a little bit of context to uncover the issues that we're talking about. So first and foremost, what do we mean by environmental health and justice? You'll find a variety of definitions and conceptual frameworks for these terms depending upon the orientation point. There really is a variable difference in the definition from government entities to public health communities to those definitions shared by communities that are heavily impacted by environmental factors. And so just considering that there are nuanced concepts, I will share a few definitions just as a reference point for our conversation today. So a definition I find valuable is from the American Public Health Association, who defines environmental health as the branch of public health that works to reduce chemical and other environmental exposures in air, water, soil, and food to protect people and communities. And this focuses on the relationship between people and the environment, promoting human health and well-being, and fostering healthy and safe communities. We achieve this through a variety of factors, through healthy community design strategies like healthy housing, healthy hospital retrofits and food systems, transportation and consumer product safety. We achieve this through protecting the national environment, so addressing climate change, air and water quality, vector-borne disease emergence and spread. And we also achieve this through partnerships and systems. So ensuring a voice for community health practitioners and justice across places. Now, defining, oh, I have a little lag. There we go. So defining environmental justice has even more nuance. From the government perspective, the Environmental Protection Agency most recently has defined environmental justice as being achieved when everyone enjoys the same degree of protection from environmental and health hazards, and equal access to the decision-making process to have a healthy environment in which we live, learn, and work. The challenge is that the US EPA has changed its approach to environmental justice over time. And currently, we see a lack of recognition of race as a unique indicator in environmental justice assessments. This is despite acknowledging that there are many studies, including one all the way back to 1987 from the Commission for Racial Justice, that acknowledged race as the strongest variable in predicting the location of waste facilities or other industries. So it's important for us to also look at this concept of environmental justice from those who consider themselves environmental justice communities. And so here are a few excerpts that are pulled from the 17 principles of the Environmental Justice and Health Alliance, which is a national network of grassroots environmental and economic justice organizations and advocates in communities that are disproportionately impacted by environmental contamination. So they operate by a network model featuring leadership of and by environmental justice groups. And you will see that in these principles, racial equity is inextricably linked. They discuss not only concepts of environmental justice, including concepts of worker health and home safety, but how it should be pursued and maintained through equitable decision-making and self-determination of all people. So these are big concepts that often are not front and center in healthcare. We often think of services provided in healthcare as being those inside the walls of the hospitals, clinics, and doctors' offices. This is clearly an important piece, not only for the curative practices, but also as a large institutions, hospitals in their operations, from what they purchase, how they treat their waste and beyond, impacts the health of their workers and their community. But as we look towards a more ecosystem model, we need to link these activities with the role that hospitals play outside of their walls, where there are communities disproportionately impacted by environmental and social factors that impact their health. The most vulnerable are often the elderly, children, low-income communities, Black people, and other people of color. Climate change and its unpredictable events are a threat multiplier for health inequities. As eloquently stated, our racial inequity crisis is intertwined by our climate crisis. If we don't work on both, we will succeed at neither. So we've seen with the onset of COVID-19 pandemic and the damaging hurricanes and wildfires and floods over this past year, I'd like to ask our speakers to share a bit of their perspective on the present moment. And so at this time, I'd actually like to ask Chip to unmute and join us on video and share a bit of his perspective. Chip?
Great, thanks, Stacia. So one of the things that we've seen is that hospitals are increasingly becoming more and more responsible for protecting the health of the communities that we serve. And I think one of the big things, if we're really looking at moving the needle on the health of the communities that we serve, we really have to look at the 80-20 rule. And that's really that studies have shown that about 20% of our health is determined by the actual health care that we receive. The other 80% is determined by the environment and our life choices. And so what we're seeing is that the social determinants of health really are playing a major role in the health of our communities. And that's when we talk about social determinants, that's everything from the environment to diet, to poverty, to employment. We're also seeing that programs may not be as impactful as places in where we are. So I always say, if we're trying to address diabetes, for example, if we have 300 people that enroll in a diabetes prevention program, we're excited. We think, yay, we do a good job. But then I ask people to take a look at, your favorite metro park or favorite river walk or something that you all use for exercise and recreation on any nice day. And you see the thousands of people that are out there. And so, one of the things that we need to do is look at, meeting people where they are, actually physically located, in creating opportunities to make the healthy choice the easy choice. So next slide. We're
I think we may have lost Chip for a moment there. So let's see if we can actually move on and see if we can hear a little bit of a reflection from some of our other speakers today, and then we'll come back to Chip if we can get his audio back. So let's see if I can move through.
sorry,
did we get to...
back there,
We lost you. Okay.
I got kicked off. I'm not, of course I'm at the, at the office and get kicked off. I would expect it at home, but not here at the office.
No problem.
Anyway,
Thanks, Chip.
So we were talking about just the impacts and the various impacts that climate change have on human health. And so there's a number of different factors that all impact this. And we can go to the next slide. And one of the things that we're seeing right now is the impact of climate change and air pollution and the impact that it's having on COVID-19. Here in Michigan, we've seen increases in the number of folks in areas where there's increased pollution, high particulate matter. And they've done studies to show that counties that have the most polluted air will experience higher risk of death for COVID-19, in part because of the impact that it has on lungs. And they're also seeing that the particulate matter, PM 2.5, even slight increases in the amount of particulate matter is associated with an increase in the COVID death rate. We think partly that has to do with the lung function and maybe disruption to the lungs where viruses and other problems with the lungs can be exacerbated. And they've seen this in the past. In 2003, SARS patients in the most polluted parts of China were twice as likely to die from the disease as those in places with low air pollution. And we've seen some studies that are continue to support that here in the US with COVID. We also have an issue with, air pollution and equity. As Stacia mentioned, you will also often find that the areas with the highest percentage of minority populations are also the areas that are the most polluted. And I think, we're seeing this with COVID-19 and the disproportionate effect it is having here. For example, in Michigan, African-American people make up just about 14% of the state's population, but they're about 31% of the total cases by race and about 40% of the total deaths comparatively. So it's a disproportionate impact on those communities, and I think it's something that we really need to pay attention to. And then finally, from a resilience standpoint, climate change is very impactful to our healthcare operations. We're seeing more frequent and extreme weather-related events, everything from hurricanes, floods, wildfires, tornadoes. Not only do they threaten the hospitals and the communities that they're in, directly, whether that's flooding. I mean, we've experienced in some of our areas, when massive rain events, parts of our, facilities will flood up. But we're also seeing other threats to supply chain. For example, when Hurricane Maria hit Puerto Rico, they were one of the major manufacturers of IV bags and tubing, and we ended up having a severe shortage of IV fluids after that happened. And so we need to look and start planning to be more resilient as we're seeing these increases in extreme weather-related events.
Much, Chip. Really important information. And I'm actually wondering at this time if Dr. Gillespie, you'd like to unmute and join us on video to share some of your thoughts.
Sure. So as Chip was just talking about, there are a lot of factors at play here. This model comes from the last IPCC, the Intergovernmental Panel on Climate Change, from their last assessment report. And it describes how both climate change and socioeconomic processes on the right influence the factors that ultimately determine health outcomes in the center. So starting at the center and working our way out, let's take the example of respiratory illness. So taking the rising temperatures and drought conditions we're seeing with climate change, these drive longer and more destructive wildfires. And we know that wildfire smoke in and of itself has a number of adverse health effects. It irritates the lungs and it causes an increased risk of pneumonia and COPD, asthma exacerbations. And then you add other hazards to the mix, like COVID-19, and you get the perfect storm. Vulnerability and exposure to these hazards isn't spread equitably across the US. Next slide, please. With coronavirus infections, we've seen examples of how certain ethnic and racial groups developed higher rates of infection and worse outcomes. These headlines come here from local news in my community in Denver. Back in the spring, my fellow hospitalists and I were stunned by the disproportionate number of Latino patients who were being admitted to our COVID units. A cluster of them came from a local meatpacking plant where they had been exposed, unable to stay home and self-isolate out of concern for losing their jobs. And we found in retrospect that inappropriate infection precautions had taken place. Next slide. So as Chip was alluding to, similar patterns were seen nationally among Black patients and formally studied. The first study here, hospitalization and mortality among Black and white patients with coronavirus. This study was published in June in the New England Journal. In a single health system in Louisiana, compared with the ethnic breakdown of their entire community, Black race was associated with a higher incidence of hospitalization. 77% of Blacks were hospitalized and 70% of the people who died were Black. And this is compared to only 31% of the population being Black. Similar themes were found and conclusions were found in this other study, the association between county level racial and ethnic characteristics and COVID-19 cases and deaths. So this is a national sample where they looked at counties across the United States and compared racial breakdown of the population and compared that with the breakdown of who was getting COVID and who was dying with COVID. And what they found was that counties with a higher proportion of Black residents had a larger numbers of cases and deaths. And then finally, last slide for 1 second. The New York Times summarized case incidents broken down by race here in July. And this was the average case incidence, 38 per 10,000 people. And white people were seeing less than average, and then Black and Latino, many more. Next slide now. So we know that Latino race and Black race are not in and of themselves risk factors. Other socio-demographic factors are at play, and this list comes from the CDC. You can see that other things like discrimination, access to healthcare, occupation, gaps in education, income, and wealth, and housing security also play in here, and these are the confounding factors. Next slide. And then underlying medical conditions also increase one's vulnerability of getting COVID or of getting sick with COVID. So asthma, you have a 1.5 times risk. These are all hypertension 3 times, obesity and diabetes 3 times as well. Chronic kidney disease 4 times, older age, and also increases the risk. And we mentioned these social and demographic factors. And then switching gears some to talk in particular about climate change. Similar health factors are at play that increase your vulnerability to poor health outcomes related to high temperatures and respiratory disease. So people with chronic lung disease, heart disease, obesity, diabetes, and extremes of age. And I liked in the chat box, there was a mention of environmental exposure. Poor indoor air quality also plays a role. Next slide. I wanted to spend a little bit of time talking about this map from Denver. This is a pattern that we've seen across the country, but just from Denver. On the left, you see a map from the 1930s. The Homeowners Loan Association put together these maps outlining where favorable parts of the community were for lending money. And in the red areas, the redlined quote unquote areas, these are the least favorable, and these tended to be neighborhoods that were predominantly Black and had immigrant the green was the most favorable. Mirroring that map with a updated or a current map from Denver, we made this map of heat vulnerability across Denver. And as you can see, the areas in red that are highly vulnerable to heat are very similar with the patterns that we see that were redlined however many years, 90 years ago. So these patterns stick around. Next slide. So what we're talking about here is we're facing 2 public health crises, COVID and climate change, both of which inequitably affect certain populations. We're emphasizing the importance of cross-sector collaborations that help address the root causes of inequity, be they primary health related like diabetes, asthma, or COPD, or related to healthcare access, discrimination, or gaps in income and education. The goal is to build resilience amidst the pandemic, amidst climate change and other threats to come. Next slide. And in the case of climate change and structural inequity, collaboration is a necessity since there's no vaccine on the horizon for either one. Thank you.
Thanks so much for that, Dr. Gillespie. At this point, I'd like to see Heather, if maybe you have initial thoughts you'd like to share as well, if you want to come off mute and join us on video.
Sure. Good afternoon, everyone. I'm just going to share a little bit about what we've seen within the YMCA as one example of a community-based organization that is trying to work in partnership with our healthcare colleagues to really impact that 80% of our health that's impacted by our environment and lifestyle. And I really appreciate that Chip shared the diabetes prevention program as an example, because I think we can potentially keep some of that theme going here. But just a little bit of what's happening in your social service sectors related to the COVID-19 pandemic and the impact of this public health emergency. Health disparities are not new, as we've just seen from even the maps previously showing the redlining and the heat vulnerability in the Denver community. The health disparities that we're seeing really have just had a spotlight shined on them. They're not new. We've seen a greater emphasis and greater impact as a result of, especially for individuals, and the rate of COVID and COVID-related deaths. Within the YMCA, this was something that came to light very early on, and we have an African-American CEO resource network across YMCAs that has really decided to tackle within the construct of health disparities, addressing the cycles of poverty, addressing the need to, the need that continues around food insecurity, which we've seen jump tenfold, if not even greater, within the Y, and the need for continuous access and improving access to health care. So that comes into context because as we look at social needs, just so I know that I'm getting cut off, I'm not sure if that's still the case. But as we look at social needs in our communities, can we go back? There we go. As we look at social needs across our communities, we know that your social service organizations are really impacted right now, same as your hospitals are, but around sustainability. So the majority of nonprofits do not have cash reserves, depending on the kinds of services that they have traditionally supported or their revenue models. When you look at the impact of COVID-19, I'll use the YMCA as an example. Our YMCAs closed their doors for their traditional services, their fitness and wellness related services. They made the quick pivot to deliver those services as remotely and virtually as possible. But then they became significant partners to healthcare in addressing childcare for essential workers. We have a lot of that happening at YMCAs. Again, our feeding program, which would typically been for students in out of school time, expanded greatly to help address needs for families and older adults. And then the sustainability of these organizations in the time that we're trying to impact the 80% of health that happens outside of healthcare is going to be something that's really critical for us to be thinking about, because we, as the community side, can't do it alone. We know the healthcare side can't do it alone. We need to do that in concert, but how that's achieved at a time when everybody is seeing nothing but these statistics and also looking at the survivability of their organizations is something I think that in partnership is going to take a lot of effort to really make that happen. The good news is we'll share in a little bit. We have some examples of where we're seeing some bright spots emerge, but just want to share a little bit about the fact that as we look at the combination of all the statistics and everything that's been shared to date, and the diabetes prevention program is a great example, you can have people who are motivated to make the lifestyle changes, who are committed to doing this and go through the process, but they live in communities that don't support their ongoing health journey. And so what does that look like? How do we help people overcome that? And how can we do that as a collective between healthcare and the community and social services sectors? So with that, I'll turn it back.
Thanks so much, Heather. So important, really acknowledges the challenges ahead of us. You know, in considering this new reality that we are just learning about, we have an opportunity, more like an imperative, to rethink healthcare and to apply that ecosystem approach where healthcare, public health, community-led and based organizations are more seamlessly connected. So in this reimagined model, we can ensure that approaches to address social determinants of health are looking at some of these environmental factors and some of these challenges that Heather had mentioned. We can move healthcare and their practices to reduce any inadvertent harms and move them into healing the harms that we see today in the form of environmental degradation or in social inequities. And we work towards achieving that goal of healthy people living in equitable and resilient communities on a thriving planet. And so with that, I'd like to ask one more question of all of you before we move into our next phase here. Are environmental factors or climate climate change strategies being addressed in your approaches to social determinants of health within your institutions? So I'll give you a moment there to click yes, no, maybe you don't know, and then click submit at the bottom there. Give you maybe a couple seconds here. Answers are coming in. Okay, great. And let's see what our audience had to say. Oh, wow. Okay. That's actually surprising to me. There's more yeses than I would have expected, which is great. But it looks to be pretty even across the board. So we have some learning to do. So with that, I'd like to see if I can enlist our speakers to help us understand a bit more of the pieces of the puzzle. And so maybe we'll start with Dr. Gillespie. I invite you back to join us on video and unmute yourself and share a bit of your background on sort of the opportunity in front of us. Oh, excuse me, I'm sorry. Why don't we start with Chip?
Great, thank you. So yeah, just a little bit about Henry Ford Health System. So we are a 5-hospital community academic research institution, all of the above. So depending on which location you are, but we are an academic research institution. We're the 4th largest research institution in the state of Michigan. We have 30 plus medical centers. We have our own health insurance plan and over 200 sites providing various services across Southeast and South Central Michigan. Right now, so if you don't mind going back for just a minute, one of the things I know Stacia wanted me to touch on is our structure now in terms of incorporating the social determinants of health into our clinical operations. And as of about a year ago, we just started a new committee structure at Henry Ford. And one of the committees that we have focused is called the Community Health Anchor Council Enterprise Wide Committee, otherwise known as CHANCE. And it reports up to our System Planning and Performance Council, which kind of makes the direction of our strategy, and then up to our Executive Council. And underneath that committee, there's a number of different work groups. We have a specific work group focused on the social determinants of health. We have one, we're involved in the Healthcare Anchor Network, which is led by the Democracy Collaborative. For those who are not familiar, it's worth taking a look and seeing if your institution might be interested in getting involved. We have one section focused specifically on community benefit, another committee focused on the community health needs assessment, and then we also have it tied in with aligning with our Medicaid strategy as well. Next slide. The social determinants of health work group imperatives, I'm not going to go through all of these, but needless to say, it's more about scaling up our system-wide screenings to assess social needs. So making sure that we're asking the questions that can get to the social needs that our patients have, whether it's food insecurity, housing insecurity, other issues that may be impacting their health and well-being, transportation, et cetera, and finding solutions for those. And the goal is to be able to then leverage the data through our electronic medical records to not only provide referrals to services, but to do continuing and ongoing research related to the social determinants of health. The next slide. The Healthcare Anchor Work Group, which is one of the ones I actually am involved in a couple of these, but the Healthcare Anchor Work Group is helping to align our Henry Ford Health System activities with the Healthcare Anchor Network priorities. And those include impact investing, so what we're doing to invest in the community to help make a difference, local and diverse hiring, impact purchasing, including purchasing from minority and diverse suppliers, sustainable procurement, so looking at the impact of our purchasing and how that impacts the environment, our waste reduction strategies, fewer chemicals of concern, et cetera, and purchasing locally, not only to help boost economic viability in the area and to improve businesses in the area, but also from a greenhouse gas emission reduction standpoint. If we could purchase locally, that reduces the greenhouse gas emissions. And there's also a section in there focused on advocacy and policy related to the social determinants of health, making sure that we're advocating for that. And then also when we're building new facilities and looking at planning around our facilities or adding new sites, that we're engaging the community in that process as well. Next. As I mentioned in the intro, hospitals are required by law to conduct, nonprofit hospitals are required by law to conduct a community health needs assessment and take steps to improve the health of the communities that they serve. So it's a condition of their nonprofit status to do this community health needs assessment. And so one of the things that we're trying to do is make sure that we're aligning the work, when we're determining what those needs are in the community, then to align our work to try to address those and really focus on trying to address those specific needs. Next slide. So for example, in the city of Detroit and in the area, the public health problems that we see are not unlike what many will see in urban areas, large urban areas, but these are the major ones that we're seeing: COPD, congestive heart failure, so coronary artery disease, those types of things. A lot of mental health as well continues to percolate up as a major factor that we are needing to address, as well as obesity and asthma and other things on this list. So next. And as you can see, the health effects of pollution all impact those priority areas. All those things that we're concerned about also, are directly impacted or exacerbated through pollution, whether it's air pollution, water pollution, contamination. They all have impacts on these different areas. So asthma, respiratory illness, heart disease and stroke, cancer. Low birth weights, we know that increases in air pollution lead to lower birth weights and higher infant mortality rates. We also have, higher toxicity for kids that are exposed to things like lead and other contaminants. There's also traffic safety, traffic issues, with that can contribute to the pollution. So how cities are designed and where trucks idle and those types of things, those all have impacts on pollution as well as traffic deaths, from that. So next slide. So one of the things that I think we really need to work on as health leaders is how to reframe sustainability as a solution to a lot of these problems, as opposed to just trying to address them clinically. So if we're looking to reduce asthma and reduce air pollution, what are the things that we can do? So we can look at increasing the use of electric vehicles, for example, or increasing those fleets and adding more charging stations as a way to cut down on exhaust from automobiles. Air pollution and social distancing. If we need to keep people healthier in a way, we can reduce air pollution and the commutes that people have and the number of miles people are driving by adding more telework and telehealth. We can also address transportation issues of people missing their appointments because they can't get to the doctor by going through telework. I could go through a lot of these things, but things like obesity, things that we can change on our menu is using less meat, having more plant-forward menus, local, getting more local food to help address some of these issues. Toxin exposures, we can walk the walk and start introducing safer cleaning chemicals and using healthier interiors with the furniture and the flooring and the paints that we use in our own facilities. So next slide. One of the things that we looked at a while back, this was even before I took on this role as Director of Sustainability, I was involved with a project with the Greening of Detroit in the Institute for Population Health, and we were looking at a healthier, greener Detroit. And one of the things we looked at, because Greening of Detroit is responsible for planting trees in the city of Detroit, we were looking at the impact that trees might have on reducing various chronic conditions. And so we looked at the studies to show which illnesses were directly impacted by the amount of green space. And we found through our looking at the literature review that we had that chronic respiratory disease, i.e. asthma, heat-related stress and mortality, and mental illness were three big areas that were directly impacted that could be benefited by having more green space and trees. And so we saw high rates of conditions in this, in each of these areas. So next slide. So we noticed that the studies did show that trees to be a cost-effective solution to remove particulate matter from the air. And trees in urban areas are most effective mitigating public health issues. These are some of the studies that we saw back when we were doing this program. And so the idea was that we were going to then take a look at the rates of exposure and the sensitivity to these illnesses in the city of Detroit, and then do some overlaying to find out if we were going to be planting trees, where would be the best place to be planting the trees. And I'll just run through these next couple of slides real quickly. But so we looked at maps based on asthma exposure, and you see the darker the color, the higher the asthma exposure in the asthma propensity we have. Next slide. Asthma sensitivity. So this is the residents that are 17 age or under, as well as seniors who were most susceptible to these. And we looked at, again, the darker the color, the more sensitive, the more folks are in that population. And then the vulnerability. So it's the combination of exposure and sensitivity kind of gets you the vulnerability index of like, so we know that in looking at this, that if you're going to plant trees, you're going to want to plant them around those specific areas. And as you can see, in a lot of those overlays, they actually coincide with these whiter areas that you see here. This is a map of the tree canopy cover. So the fewer the trees that we have there, you see higher incidence of things like asthma, for example. And we did this for all three of those illnesses and came up with some recommendations on ways that we could be directing tree plantings and green space as a way to help mitigate some of these, the impact and improve the health of those communities. So moving forward, a couple of things that we're working on right now at Henry Ford Health System through our Sustainability Community Benefits Program. We're trying to address the social and environmental determinants of health. One of the things that I've been trying to push us on is to do a Healthier, Greener Homes initiative where we're actually going to hopefully start screening for issues related to home and neighborhood conditions. Everything from, are they having trouble paying their water bills or trouble with their utility bills? Is their HVAC working, or do they have lead in their building or in their building or in their home? All of those things can have some impacts on people's health, and then referring people to programs to help address them, whether it be utility rebate programs or retrofits. We can do those. We've been working on a program on food insecurity. It's Henry's Groceries for Health, where we screen people for food insecurity, and they actually get a prescription for regular deliveries of healthy foods and groceries to their homes. So, and we've been seeing tremendous results with that program, and we're looking to expand that as well. We're also right now partnering, mentioning the plumbing and HVAC things. We're working on a program right now using water bottles. We've got a new water bottle filling program that we're going to be launching soon. COVID put it on hold a little bit, but there's a water bottle where you, with a company called Companion, and fill it forward, and you basically scan a barcode on your water bottle, and whenever you do that, they donate 2 cents to a water charity that helps to provide water, clean and safe drinking water to various charitable organizations. We ended up selecting a charitable organization here in Detroit to help with plumbing repairs in people's homes, because there's a lot of issues with water insecurity just here in the city of Detroit. And we've also been doing a lot working on the transportation side of things. We recently sponsored a Bikes for Essential Employees program, as well as partnered on a e-bikes and e-scooters initiative to help get our essential workers to and from their jobs more efficiently and more reliably. We're also going to be focusing more on looking at other healthier transportation options to help reduce greenhouse gas emissions moving forward. So a couple of things that we're looking at that are related to those social determinants of health.
Thanks so much, Chip, for that. And I'd actually like to invite Heather back up and see if she would like to share additional context and information.
Sure, thank you. And I'll be quick. I know we want to save time for discussion. So a couple things around how the Y has been responding, specifically in this clinical community connection during COVID-19. So next slide. I highlighted this a little bit, but in case you're not familiar with the structure of the YMCA, we are a federated nonprofit, which means we have 800 501c3s that make up the network of YMCAs all over the country. And YMCA of the USA serves as the national resource office for those Ys. Next slide. So here's a little bit more about the impact of COVID-19 on YMCAs around the country. As I mentioned, we closed our buildings to sort of our traditional fitness and wellness in a lot of those areas. And that had a significant financial impact on lost operating revenue. Again, nonprofits don't carry significant cash reserves. And unfortunately, as we all know, how COVID has grown or the public health response has varied community to community. But in the Y, we anticipated and likely saw because, summer camps didn't look the same. Oftentimes, the majority of resident camps didn't open. And YMCAs had to lay off or furlough 75 to 95% of their staff. At our national office, it was at 40%. So it's been a pretty rough couple of months. However, just because the buildings were closed, as I mentioned, didn't mean the Ys themselves were closed. So this is how we responded to address a lot of the social determinants and support the essential services within our communities. So as I mentioned, emergency childcare sites was a significant transition. YMCA's met the public health needs through CDC recommendations on everything from the number of kids per pod, et cetera, temperature screenings, trying to get a hold of PPE to be able to support this was a lot. But this happened often in partnership with their healthcare partners who needed places for their employees to have safe options for childcare. As I mentioned, also, our food programs really expanded beyond the out-of-school time for children to children, adults, and older adults. And we often heard people say, I've never had to get food before. This is the first time I've ever faced this challenge, with obviously the economic impact happening around the country. We also know that YMCAs were conducting wellness checks. They were calling the seniors in their communities, which really helped produce not only calls around this, but the opportunity to address the needs that were raised. So we had pharmacy drop-offs, prescription drop-offs. We had, again, food feeding programs. And there were also partnerships around blood drives. Lastly, I'll just add, it's not on the slide, but it's another example of a response. When schools went back in this either fully remote or hybrid models, YMCAs have partnered to create virtual learning labs so that there was a little bit of structure and the opportunity to help kids be physically active during the day. When we looked at the challenges around screen time and this fully remote environment, what does that look like and how might we help support that? So you'll see learning labs having popped up all over the country, and YMCA is trying to address that need. Next slide. While we had the opportunity to we're a 175-year-old organization, and I think I've heard a few people describe it as we had to sort of turn the the barge in record time. And one of the blessings of the pandemic, honestly, was that it really fast-tracked the work we were doing in virtual and remote service delivery. We are typically very much historically an in-person model of service, and this helped us very quickly turn service offerings into remote options. And so we launched YMCA360.org very early on in the pandemic, which had a bunch of recorded content. It was free to consumers. It still is. Feel free to check it out. You can drill in on different types of options. Here's some examples of some older adult programming. YMCAs themselves shifted some of their in-person lifestyle and behavior change programs like the diabetes prevention program into remote services as well. Oftentimes what we're hearing at the community level, and I just had a CEO say this the other day, is we're expected to provide 100% of the services, but sometimes with less than 50% of the resources to do it during this pandemic. Less money, less people. I know I'm not saying anything that some of you aren't experiencing in your own environments, but the ability for us to do something remote has also helped us try to figure out how we can do some things in person. And then I think this is our last slide. You can go to YMCA.net for more specifics around how WISE have provided critical services during the pandemic to address social determinants. We have a lot of examples of the community level changes. A lot of YMCAs who have focused in on, we've been having conversations about what the next 18 months look like, but also what the next 5 to 10 years look like, and how, as an organization, we can work in partnership with organizations like health systems and hospital systems. Many YMCAs participate on the community health needs assessment teams. All those ways can help you engage the community in the creation of the future solutions that help meet the needs of the communities that we all serve. So with that, Stacia, I think I'm going to turn it back to you so we can get to next steps.
That's great. Thanks so much, Heather. And with that, I'd actually like Dr. Gillespie to join us again and share some final thoughts before we move into a short discussion.
Thanks, Stacia. So I'd just like to give an overview of kind of what my community looks like, the tools that we have, and confronting the challenge of climate change in particular. So go ahead to the next slide, please. This is just an overview of what Denver Health looks like. We're actually an integrated health network, and we are made up of all these parts, including Denver Public Health, our hospital, and the Poison and Drug Control Center, which gives us a lot of tools in confronting community health issues. Next slide. Everybody knows this is Colorado. This is where we are. And we are at elevation and right next to the Front Range, which leads us into the next slide. These are just some of the climate hazards that we're facing. I won't read through all of this, but they're basically they basically are drawn from increased temperatures, poor air quality, because of how the convection works next to the mountains, worsening drought, and then therefore more frequent and destructive wildfires. And next slide, please. This is kind of a visual cartoon of all of the health hazards that really stem from climate change and how they are affecting health in the community. So I'll let you read through those, but there are multiple different downstream effects here. Next slide. I won't go over this slide in detail. I added this just to give some background of what we're facing with climate change and the fact that CO2 levels are climbing at record levels in an 800,000 year time frame. And this is associated with increasing average global temperatures, the scale of which will really be determined by how well we cut carbon emissions as a world economy. And moving on. And I wanted to talk a little bit about how we're confronting climate change as a community. I'll briefly go over some of the research that I'm doing that is working with this heat vulnerability map that I talked about a little bit earlier. And then Chip mentioned the community health assessment. I'll go over some of the themes that we discovered in ours. This is a picture from 2014, but the one more recently, it hasn't been published. And then talk a little bit, well, actually, this is just the pictorial description that I was going to talk about, that just talks about what tools that we have in our community and a few of the entities that are thinking about climate change and health. And these are all the ones that I could think of. I'm sure there are more that I have yet to discover. I'll let you read through those there as we go on to the next slide. So the research that we're doing, I'm collaborating with some epidemiologists at the department at Denver Public Health to address the social determinants of health as they relate to high temperatures and medical and demographic, medical comorbidities and demographic factors. And we are using this map to determine basically a score of the Denver Health population compared with the rest of Denver, according to where they live, using the map. And the second aim is really the meat of the project. And we're looking at retrospectively to look at the associations between residential heat vulnerability, how healthcare utilization is occurring, and then how this is occurring on whether on high heat days, so days over 90 versus other days. And we're going to be stratifying our results according to comorbidity, race, ethnicity, and a number of other factors. And our hopeful outcomes are to do what a sustainability officer like Chip would support. We don't have one, so this is kind of more grassroots, but we're hoping to influence community resilience for these issues and really find out where, correlating with utilization, where we can intervene and where we can help build this resilience against heat illness. Next slide. And we don't really have time to go over this, but these are just some of the themes that came out, completely unsolicited environmental themes that came out of the health assessment. These are the questions that were asked, and these are some of the themes that we noticed that were directly tied to environmental concerns. Moving on to the next slide. And I thought this was a good summary quote. The involvement of, and this was taken from a paper from the New England Journal in 2015, the involvement of many parts of society, including governmental agencies, health organizations, clinicians, the private sector, and communities is increasingly important for success. Everyone benefits when the environment I put in is healthier.
Well, a special thank you so much to our speakers, Dr. Elizabeth Gillespie, Heather Hodge, and Chip Amo. I think you've really given us a different perspective from public health and healthcare and communities. When we think about this sort of pivot needed to embrace an ecosystem approach to caring for our communities and for our health as we're approaching major disasters, unforeseen disasters like pandemics and climate change. So thank you for that perspective today. And actually, before we wrap up, a couple of more announcements. As previously mentioned, we are providing a recording of this event as well as the slides to all registrants. You can also view any past sessions by visiting cleanmed.org. I hope you will join us for our next and final session, Clinical Sustainability. This is going to be fascinating content that's held in partnership with the Yale Center on Climate Change and Health. And if you're feeling ready to really get your hands dirty, I encourage you to join us in our healthcare culinary contest. We've streamlined this year for much easier entry. So connect with your hospital chef or your food service director and submit your entry anytime between now and November 30th. So thank you again to everyone for joining us during this challenging time. We're thankful to have so many wonderful collaborators and champions. And with that, best wishes for a productive week. Thank you.